Diabetes and mental illnesses, we know, are largely either psychiatric illnesses or the psychological issues connected with diabetes, or even the affection on the cognitive functioning, and then the societal issues. So with that, my first question would be to Dr. Panda, sir. We have discussed the spiritual aspects of dealing with diabetes, depression and diabetes, and also the psychosocial guidelines in type 1. What are the other common mental health issues that one comes across in those living with diabetes? And we all understand that COVID-19 had precipitated a lot of these mental health issues anyway, even in those without diabetes. So what are your views on this?
Yeah, we daily come across such patients. The good thing is that we screen every patient for diabetes in our clinic. And then daily around 5 people, we tell them that you have diabetes, who never knew earlier. And after knowing that, they react so vividly. Many defy us, many argue with us, many tell, why are you testing and giving us tension without any reason? Many go and cross-check in 5, 6, 7, 8 places, and then the anger, the non-belief of the report, and the breakdown of such a news. We have seen all the reactions in our clinic. So the most important thing to accept a chronic disease, the people, especially from low socio-economic status or the middle socio-economic status, they just deny to accept. And many people, they don't want to test, don't want to treat, and they stay as such till they develop complications. So as Archana ma'am told in her interview, it's very important, the first interview after the diagnosis with the patient, maybe type 1, maybe type 2, maybe GM, maybe category. We cannot give it to our counselors, educators, or the people around. And it has to be very safe. We have to break the news very gently so that the person will accept. And then the reactions are varied. And many times they become angry, they become depressed, they break to tears. And then there are few people, they go calmly and cross-test and cross-check it other places and come. So this has been a regular affair. So my suggestion at this juncture, once we know that there are issues related to breaking of the news, is related to mental stress, we have to do it very smoothly, counseling them that this is a part of life and so many people in the world are suffering. You have a history in your family, and you see, I make them talk to people in my clinic, the diagnosed patient, those who are on treatment for 5 years, 10 years, 15 years, 20 years. I ask them, you go and talk to them and see how they were diagnosed and how they were managing. And then that interaction is very important to find out a solution. But they have all type of reactions, the depression, the anger, the denial, the argument, and breaking to tears and going around. And it has to be very sensibly dealt, not to hurt them or pursuing acceptance of a chronic lifetime disease.
Absolutely brilliant answer, sir. Also, I think it's not just the patient, but it's also the family that responds to the person with diabetes. So that family distress is also something that adds. And I think two things that clearly lack sometimes is what ma'am also highlighted, that empathy and the time that's required for offering that counseling are also required. So with that, we move on to Dr. Surjit Sahu, sir. Does every patient with diabetes require psychological assessment? And what are the reasons for referral to you, sir?
So normally when the patient develops diabetes, so what Jayantapanda sir has already pointed out, that there is denial is there, because why I suffer from diabetes. And when you explain that your family history of, then you may develop the type 2 diabetes is there, and other things, then you are having so much of stress is there, then you have suffered this type of diabetes. And but with that explanation, people do not accept it very well, because actually when there is a matter of death is there, then people are very quickly accepting that and serious about all the disease. When it takes delayed death and suddenly it is not it is also a silent killer, then people do not accept it very quickly. This is about what happened in the our recent corona practice, the first wave, second wave, and ultimately third wave. People are very much callous about not putting up masks and other things. So see, because government told that there is no more chance of complications, so spreading it much more. So like this, these people go for this type of, and actually in the first setting the people are having an acute problem of anxiety and denial, but when the diabetes is around, type 2 diabetes is around 5 years, then the people develop depression. It is both due to diabetes and some restrictions we pose on these patients, and some restrictions due to diet and other things. So during that time, most of the people, they should be actually screened for this depression, because we all know depression, and we all prescribe antidepressant medications, and we all know about depression. But thing is very important that how many days he should continue, because depression is in the first stage. When there is a moderate depression or major depressive disorder, we normally treat the depressive disorder for 6 months interval of symptom free interval. So 6 months to 1 year is normally to be treated. But thing is that most of the time these people are under treated. This is the most important thing. When the patient do not have that amount of energy to commit suicide or to do something wrong, and he is not being uplifted, so we are treating with suboptimal dose of antidepressant medication. This becomes a problem to this patient. Otherwise, it is not problem. We all know, we all treat, and this is also the treatment part. And after 5 years, we get this. And the referral part is to the treating. Referral part is to the patient to this psychiatrist is most of the time when the patient is having a major depressive disorder, or the patient is having suicidal thoughts, or the patient is not responding to the single medication, or some other comorbid psychiatric illnesses. Schizophrenia, because schizophrenia is sometimes associated with this suspiciousness and delusional problems, and with that antipsychotics are having putting weight, adding weight to this medication. Along with this medication, the people gain weight. So these are these most important conditions where to refer. Otherwise, simple depression to be treated at every physician's end, but it should be adequate. And if we are saying that within 2 months time period, the patient is not relieved from his symptoms, they should be referred.
Great. Wonderfully explained. Yes, sir, please.
Purvi, I want to ask Professor Sahu, this is a very delicate issue. Wife is diabetic and is going into depression. Okay. If your husband takes her to a psychiatrist, then there is a big problem. If husband is diabetic and depression, if the wife says that you must go to a psychiatrist, there is also another family trouble. At this stage, a friend, somebody who is wife's friend, must tell her slowly over a period of time that why don't you see or consult with someone who is a psychoanalyst. It may be you, but psychiatrist, going to a psychiatrist, sitting in that waiting queue and seeing other psychiatric patients is always a big problem. I referred one lady to you, and after half an hour, her husband scolded me. Where have you sent us? It is a psychiatric problem. Is my wife is mad? So these are the things which should be very delicately handled, and even referral needs to be very delicately handled. Thank you, Purvi.
Sir,
another thing I want to add here.
Yes, sir.
If the patient is having comorbidities in the form of cardiovascular illness, in the form of CKD, in the form of different complications, maybe neuropathy, maybe retinopathy. The more the complicated the state, more is the chances of depression because of the poor quality of life, I have noted. And second thing, if the person is a atheist, he doesn't believe God, he doesn't surrender near God, and he thinks that he is the authority who will decide the treatment and the approach, he is more likely to be depressed and be broken in the challenge. Those who believe, they go to the temple, pray near God, come with the caregivers, try to rationalize that God has given this disease, he will give us a solution, we'll try to fight it for the rest of our life. They rationalize. But those who don't believe a supernatural power and devoid of spiritual belief, they are more likely to succumb to the shock from this chronic disease.
I also would just like to mention that I totally agree. This is something we observe. And as far as psychiatrist referral is concerned, it takes a long time to convince them. But one thing I would like to share that I totally believe that we have to convince them to go to a psychiatrist. We have to take away the taboo because we cannot treat them the way a psychiatrist can. And we cannot see all the other aspects. So it's a very, very structured clinical diagnosis, and things that seem like depression can be actually something else. So that faculty is, is really to be respected and convinced that it is like that. I tell my patient it's like diabetes. You have blood sugar here, insulin there. There is something in the chemical in your mind that. So you just have to somehow manage to convince them to go to a psychiatrist. That's for us. Many people I see treat with antidepressants, with relaxants, and even mood elevators randomly. I see prescriptions as an add-on to every physician's prescription at the end, and which is pretty scary. I think that is not the way we should go about it.
And because
or we should get ourselves trained.
Yeah, because of the stigma which is associated with the psychiatrist, better you can refer them to a neuropsychiatrist or a brain specialist. I tell them because of reactions in the mind, I am sending you brain specialist. Because if you tell psychiatrist, वो बोलेंगे मेरे को पागल डॉक्टर के पास भेज दिया. That is the problem.
Sir, I'll just intervene in this section. Sir, actually, just see. Sir, the stigma lies with our colleagues. The most important thing is that the stigma lies with our colleagues. That is the most important. Sir, as a senior practitioner and everybody senior person, the doctors are always very bad patients. But if the doctor is able to convince about all these things, doctor is the most important convincer. After the family member, next the convincing person is the doctor. Sir, we should not blame the patient, sir. Most of the time, we as a busy practitioner, we do not give time to the patients, sir. That is the most important thing. We do not give that amount of time. Not that, sir, I am not telling a single person or something else. Sir, this happens. Sir, in our setup, we actually do not give that amount. We do not spare that amount of time to the patient. And another important thing is that we do not have that amount of time to counsel the patient also, sir. Sir, very rarely, if you are seeing 30 patients per day, then you are able to counsel. If you are seeing more than 50 patients per day, then you are not able to counsel. This is the, sir, most important thing behind this scenario. And the stigma lies along with the patient. Patient who have stigma. But I have seen, sir, we have a study, the lower income group and those people who are less educated, these people are better convinced than the educated and Google educated people and this Google using people. So that is the most important problem. Problem does not lie. Problem lies with that colleagues. And I just tell one of my friend told that the Sujit and that patient did not go to the SAM hospital. And I thought that I would write this one antidepressant. I just asked him, you continue this antidepressant, but you do not know whether it is a bipolar depression or unipolar depression. If it is a bipolar depression, then patient would have been switched to this antidepressant may switch in the bipolar disorder, and one phase is manic, and in hypomanic he may commit suicide. This also happens many times. So these are this actually nuance practicing our practice, and most of the time, sir, we do not refer this patient in the proper time. So if the patient will come to this doctor, definitely, sir, you see, our bulk of the prescription is mostly somatoform disorder and mostly non-infectious disease. Infectious disease is coming to you once and with the complications, but non-infectious disease patient is visiting you regularly. So there will be compliance, non-compliance issues and other things are there. That is the most important part. Okay.
Very well said, sir. But just taking that thought forward, if you can give us very quickly simple screening steps at that may be adopted by physicians, diabetologists, endocrinologists to detect mental health issues in those with diabetes.
So ma'am has already told that.
Time is ticking. I'm going to go a little faster, sir.
So ma'am has already told that it's about PHQ-9 and also prime MD available. Simple depression 9 questionnaire is there. From that, 2 questions are from total 5 questions to be patient diagnosed to be major depression. And so that is simple. That is, if you look out this patient face also, you can know that the patient is having depression. Sir, I always tell and recommend that people should use antidepressant, but people are having stigma, and also doctors are also, sir, see, many people are prescribing intizolam, clonazepam, lorazepam, and all this type of benzodiazepines. But when the patient comes to the psychiatrist, they think that he will be addicted to this medicine. This becomes the problem. Sir, see, this is about the stigma of this treatment planning. This is nothing else.
True. Thank you, sir. Dr. Archana, ma'am, how prevalent is diabetes distress in India, and do we as physicians actually contribute to it? And if you can give us some tips of dealing with it also.
So I do not have a number of how prevalent it is from the studies, but 1/3 patients they mentioned in the study had actual depression, which was just shown by the other speakers. But yes, I think doctors contribute to it. So I am very candid in that. And because I get patients who in their first visit, as sir mentioned, as I mentioned, the first consulting is very important. So now, right now, there's this whole theme going around which says language matters. So it does matter, that whole autocratic methodology, which was 50 years back, I am the doctor, you're the patient, main bol raha hu, aap suno, that is not what works anymore. And the first time when the patient comes in and you say, oh my God, you have 500 sugar, your kidney is going to fail. And that patient lives his entire life in the fear of kidneys failing. I have patients who check their KFT with every blood sugar level because they're always worried that their kidney is going to be failing. So the first visit, the first consultation, the first month till they are stable is a very important hand-holding time. And I think if we could do that, the rest, of course, they will read, they will learn, they'll get scared, everything will get handled. But one point I think which can really make a difference is the first consultation, the first month of empathy can make a big difference.
Perfect, ma'am. Yes, sir. Sir, if you can also touch upon euthymia, because I know you are an author on that paper as well.
Euthymia, we have brought that particular element into diabetes practice. While we said that 3 things we spoke and wrote about. One is euglycemic happiness. Whether euglycemia prevents complication or not, euglycemia gives you a sense of well-being. So euglycemic happiness is a term which has been accepted world over, and people want to enjoy this concept of euglycemic happiness. Euthymia is a sense in which we have an overall harmony and totally patient is at ease with the doctor, and the doctor is at ease with the patient and themselves, and it's a type of attitude inside the body, which I think Jayant touched upon by calling upon Sthita Pragya. That means we are absolutely love ourselves and also love our patients. And you radiate. Euthymia is a state in which you radiate the happiness all around. It's a question of happiness. Now, I would like to contribute 3 sentences. Number 1 is that I have seen many cases, Purvi, where people do commit suicide, and we regret that why we did not refer the patient earlier to proper psychiatrist. That is a very important issue because they make the difference. Number two is that today is the day of specialization. So we cannot do it. But only thing, as what Jayant was referring to, we have to develop a rapport with the patient, and also rapport to whom we are going to refer and how he communicates with the patient. Majority of the patients, people today have this communication skill. What you said, that how to communicate. We call it care by the ear. Ear care by the ear means you listen to the patient who is saying, and there are 5 issues by which we communicate to the patient with absolute empathy, and we put ourselves in the place of the patients, and we say, because the diagnosis itself gives a shock. Why me? The report may be wrong. What scene I have done, and how am I going to manage? So things are all better by the way you communicate. Before I leave my speaking, I'll just like to speak this much, that human body is not only flesh, so flesh, blood, and muscles. We have a deeper consciousness, which Jan did refer to. It is not on the surface, but this is referred to by many ways in many ancient and recent literature. People call it factor S. People call it that factor. People call it Brahman, Atman, Purushottam, presence within you. So there is something within us which is different from the body, from the mind, and from the life. And this particular thing is the consciousness with capital C. And as beautifully Alok put it, it is not religion. I'll repeat 3 times, it is not religion. It is not religion. It is much above religion. It does not distinguish any religion. It is within everybody, Mohammedan, Christian, Sikh, Hindu. So it is above religion. And this consciousness approach to healthcare or diabetes care is what John spoke about. Now, I will end by saying that even when you define health by Park PSM book, we always say that not only absence of disease, but total physical, mental, vital, and spiritual health. So this spiritual health, gradually people are recognizing and coming into foreplay, and which provides you the protection and the treatment. No, there is a coronavirus everywhere in the town, but some people get it. Some do not get it in the same situation. Why? Because they have a resistance through their consciousness envelope, which is built with faith, built with absolute harmony. They are not distressed, not agitated. There are influenza pandemic. People get it and some people don't get it. So I think mind has a great influence, capital M, and vital has a great influence. And we have to recognize that, and more people recognizing it. There's a branch of medicine I have developed called mind body medicine, MBM. We had 2 meetings last year, and I must tell you that this mind body medicine has a great impact on diabetes. And I remember the psychosocial aspect was not in the ADA SOP, but it was 2017 when Dr. Kalra wrote to ADA. We all decided, and he wrote saying that we're telling customized care. But what is the customization for the psychology of the patient? Customization for the socio-economic status of the patient. Customization for the attitude of the patient. So this has been accepted today, and psychosocial aspect, psychosocial care, the consciousness approach, the true approach where the specialists from other fields can deliver the goods are well accepted.
Thank you, Professor Das. As one of the latest articles in Scientific American, we only know 10% of the brain.
Correct.
There is a 90% still we don't know. So that 90% decide many things. So we have to keep our mind open, our options open, and our attitude and activities open. Then only we can serve ourselves and serve the society.
I learned one thing, exactly what Alok is telling. The diagnosis or evidence-based medicine practice is not doing a mathematics and arriving at the diagnosis. Diagnosis occurs to you. When does it occur to you positively? When you are in true consciousness. There are times and the times of the day when you're absolutely conscious, empathetic, open to the patient's complaint. We want to find out what's wrong with the patient. The diagnosis occurs to us. It's a sixth sense beyond the touch, body temperature. It's a sixth sense which takes over and you diagnose. There are times we make a wrong diagnosis with the same man, same alokanungo, same knowledge, same huge experience. So I think the consciousness approach very important, and it is very happy that we had this session. And you know what Archana said is absolutely fabulous. For the type 1 diabetics, what she said is very important, because they are in the absolutely, they're clay, and one can make out of the clay strong soldiers, or one can make clay out of weak soldiers who will break down in 1 year time. So children are like flowers, and children are like the unborn songs and unseen heroes, and it is our duty. Every child with type 1 diabetes has to be given empathy, has to be given that he is not alone in the fight. And we are all with him, and we give everything possible for us. Beautiful. I think, Surjit, your talk was great. And Archana, I always approve you.
Thank you, sir.
Very much. And Jan, for highlighting a different aspect of psychos. We should take it up now. And we have 2-3 heroes. One is Sanjay. One is we work with a gentleman in Pune called Deshpande, what's the name? Vaishali did the meeting last time. I think you were there, Acha. Vaishali Deshpande did that mind-body medicine. And we have got few foreign collaborators. So I think it is coming in a big way. And I mean, one can be also a matter of fact doctor. One can be atheist, but it does not matter. But what gives you pleasure to do it? It gives you pleasure to say that when I'm writing prescription, somebody's hand is on my shoulder. I mean, when I'm seeing a patient, I mean, somebody is there to tell me you don't fall into the trap of sex, money, or false pride, or wrong prescription, or unethical things. There's somebody guides me. So that's what is important in life. Thank you very much.
Thank you,
Sir,
Professor Das.
Can we
I'll
add
just
this
add one.
to the
I'll
chapter
just
of the diabetes management? Can we see that this is incorporated, the spiritual health, the mental health, the psychosocial health? Because many times it ends with the medicines, insulin and the diet and the exercise. That's all, full stop. It doesn't go further. If Professor Ashok Das will want, in the books will come, the next monogram will come on the mind, body, medicine and diabetes. And then it should be a complete volume, so that you will draw attention.
Just small example, we have written about insulin overwhelming us. Just imagine a child taking insulin 3 times a day, because type 1 diabetics, I don't give less than 3 times. It must be 4 times. 3 times a day, every day, almost at the same time, year after year, day after day, week after week, month after month, day after. So we call it insulin overwhelming us. So people have given solution, Archana. How do you get out of this insulin overwhelming us? So how do you say the child is not overwhelmed by this giant 3 times pricks in a day? So there are beautiful things that are emerging, and I think we are on the right track. Especially in India, we have to take the lead, because if anyone has to take a lead on the mind-body medicine, spiritual aspect of the English medicine, the delicate aspects of our practice, it must be we.
Also,
Sir,
NUCD led the pleasure of NUCD to publish the first book on mind, body, and diabetes.
I'll start and wait.
And under your leadership.
We'll do it.
So thank you, everybody.
I'll add one thing. Sir, please 1 minute. Sir, it is about actually WHO has given the definition from 1948. Yes. Whatever definition about health we are telling about, that's given from 1948. So see, 70 years is gone, and still we are not able to understand this about this mind, effect of the mind, and also spiritual health, because they have already given 70 years back. So thanks, Jayan sir. Actually, I just presented about this mind, and Archana ma'am had presented both the body and mind, and Jayan sir has presented about the soul. It is beyond something mind. And thanks, Professor Ashok Das and Alok sir, to invite me for this presentation, and also hopefully we are there to enlighten something like squirrel to some of this diabetes forum. Thank you all.
Your presentation was great, Professor Surjit. Now, why I told Ashok sir knows what supramental is, what level of consciousness we can live in and promote this, because he's part of the Sri Aurobindo and Mothers group in the Pondicherry, and if he wants this approach can popularize, and NUCD should take over this move of promoting diabetes and mental health.
We'll do that. And I thank Professor Das, Professor Jayant Panda, our dear Purvi, for conducting the session so well.
And our questions, great Purvi, where is she? Yes, she's here.
And Professor Surajit and dear Archana, everything was great. And now I request